Drugs and behavior. Introduction. In this study session, we will examine the effect of drugs on human behavior. When you have studied this session, you should be able to 1. Define drugs. 2. Describe the effects of psychostimulants on human behavior. 3. Mention the influence of sedatives on human behavior. 4. Describe the effects of sedatives on human behavior. 5. Describe the effects of hallucinogens on human behavior. 6. Describe the effect of antidepressants on human behavior. Meaning of drugs. The study of drugs, called pharmacology, is rooted in the Greek word pharmakon, having 3 principal meanings as a charm, an object thought to have magical effect, 2. A poison, and 3. A remedy or medicine. Drugs are also called psychoactive agents or medicine used in treatment of a disease. Drugs are chemicals. They work in the brain by tapping into the brain's communication system and interfering with the way nerve cells normally send, receive, and process information. Some drugs, such as marijuana and heroin, have active neurons because their chemical structures mimics that of a natural neurotransmitter. This similarity in structure fools receptors and allows the drugs to lock into and activate nerve cells. Although these drugs mimic brain chemicals, they don't activate nerve cells in the same way as a neurotransmitter, and they lead to abnormal messages being transmitted through the nasal network. Other drugs, such as amphetamine or cocaine, can cause the nerve cells to release abnormally large amounts of natural neurotransmitters or prevent the normal recycling of these brain chemicals. This disruption produces a greatly amplified message, ultimately disrupting communication channels. The difference in effect can be described as the differences between someone whispering into the ear and someone whispering into the microphone. When drugs are taken either orally, intravenously, by inhalation or otherwise, they act on the functioning of the brain, as thereafter they affect the brain and behavior by changing synaptic transmission. In careful consideration of what drugs are and how they affect human behavior, the neurotransmitters which are released from the terminal buttons of neurons, which diffuse across synaptic clefts, will be carefully analyzed, and other drug behaviors will also be considered, not forgetting drug dependence, drug abuse, and withdrawal symptoms, which are some of the behavior of drugs in the body. Classification of drugs. To a behavioral scientist, drugs can be classed by molecular structure, biochemical actions, and behavioral effects. This can be illustrated as follows. Drugs classified by molecular structure: amino acids, monoamines, benzodiazepines, alcohols. Drugs classified by biochemical actions: receptor blockers, mimickers, synthesis inhibitors, false transmitters. Drugs classified by behavioral effects: psychostimulants, sedatives, hallucinogens, antidepressants. Psychologists are more interested in classification involving the behavioral effect of drugs. Many of such could produce some alterations in behavior or physiology, such as increasing arousal level, combating depression, lowering blood pressure, and so on. Psychostimulants. Psychomotor stimulants are a group of drugs including cocaine, amphetamine, methylphenidate, ephedrine, and catenone that produce wakefulness and arousal and stimulate behavior. Their current clinical use is limited to treatment of specific sleep disorders such as narcolepsy and certain childhood behavioral problems such as attention deficit disorder. More importantly, the psychomotor stimulants are a class of drugs widely self-administered for non-medical reasons. History of psychostimulants. Psychomotor stimulants have been used throughout recorded history and in almost all parts of the world. There are records of Chinese physicians using the ephedra plant, Ephedra vulgaris, to produce mahong over 5,000 years ago. The active ingredient ephedrine was isolated in the 1880s, but it was not characterized until the 1920s. There is evidence that Indians of South America chewed leaves of the coca plant as many as 2,000 years ago. The active ingredient cocaine was first isolated in the 1800s. Cocaine in its various forms, including powder, freebase, and crack, is currently one of the most popular street drugs in Western history. In East Africa and the Middle East, leaves of the cat shrub, Cata edulis, have been chewed for their stimulant effects for at least 700 years, and this practice continues to be widespread among young men of this region. The active ingredient in cats, catenone, was not isolated until the 1970s. The use of cocaine for medical purposes was popularized by Sigmund Freud in the 1880s, who suggested that it was a miracle drug, with uses ranging from local anesthesia to the treatment of depression, indigestion, asthma, neurosis, syphilis, and drug and alcohol addiction. Based in part on Freud's endorsement, the use of cocaine became very popular. It was widely prescribed by physicians and even appeared in popular tonics including Coca-Cola. Although coca leaves are still an ingredient in Coca-Cola, the cocaine is removed before they are used in the drink. Presently, the only approved medical use of cocaine is as a local anesthetic. The characterization of ephedrine in the 1920s led to an interest in developing and testing similar drugs. Ephedrine was being widely used to treat asthma, and there was an interest in finding a synthetic substitute for the drug. Amphetamine, a drug similar in structure and activity to ephedrine, arose from this interest. Although amphetamine had been synthesized almost 40 years earlier, the interest in ephedrine led to the further characterization and use of this drug. Since then, many analogues of amphetamine have been developed and characterized, including the popular street drug methamphetamine. Amphetamines have been widely used for their stimulant effects. They were used in World War II by the United States as well as others to decrease fatigue and increase alertness of soldiers. Truck drivers have used them for decades to increase wakefulness and alertness and allow them to drive for long distances without stopping for rest. Likewise, these stimulants have been popular with college students wishing to stay awake and study for exams. The first condition for which amphetamine was used clinically was narcolepsy. Although it is not curative, it revolutionized therapy for this condition by making the patient relatively symptom-free. Since then, amphetamines have been used at various times to treat Parkinson's disease, depression, epilepsy, psychopathic states, attention deficit hyperactivity disorder, and obesity. Because of their ability to decrease appetite, amphetamines were widely prescribed for many years for individuals wishing to lose weight. Because of their risk of abuse and dependence, use of stimulants have been considerably reduced over the years, and newer, more effective agents have been demonstrated to work in treating some of these conditions. Behavioral effects of stimulants. Psychomotor stimulants, most notably cocaine and amphetamine, produce a characteristic stimulation of behavior in both humans and experimental animals. At low to moderate doses, these drugs induce wakefulness, increase activity, decrease appetite, and stimulate the sympathetic nervous system. In humans, these doses also produce feelings of euphoria, well-being, and self-confidence. The latter effects are reflected in experimental animals as powerful reinforcing actions. In appropriate experimental situations, animals will work extremely hard, sometimes to the point of death, to obtain these drugs. At higher doses, the psychomotor stimulants produce stereotypic behaviors. Stereotypic behaviors are typically brief and highly patterned behavioral repertoires produced in a repetitive manner. Stereotypes in humans produced by high doses of stimulants include repetitive or continuous arranging of objects, baiting, house cleaning, mechanical work, grooming, and persistent repetition of words or sentences. At very high doses, the psychomotor stimulants produce a psychosis characterized by vivid hallucinations and paranoid ideations, often indistinguishable from paranoid schizophrenia. Mechanism of action of stimulants. Psychomotor stimulants produce their characteristic behavioral effects by increasing synaptic activity of the monoamine neurotransmitters dopamine, norepinephrine, and serotonin. They are called indirect agonists because their primary effects to increase the ability of the neurotransmitters to act, without having a direct effect on the postsynaptic receptors of these neurotransmitters. Although producing slightly different cellular and muscular effects, the final outcome of each drug in this class, an increase in monoamine activity, is quite similar. Cocaine acts primarily by blocking the reuptake of monoamines. Reuptake is the first step in the process by which monoamines are destroyed in the brain. After they are released, these neurotransmitters are actively transported back into the cell from which they were released. By blocking reuptake, cocaine increases the length of time that the monoamines can activate their receptors. Amphetamine has more varied cellular effects than cocaine, increasing the activity of monoamines in several important ways. 1. Amphetamine stimulates the release of dopamine and norepinephrine from catecholamine nerve terminals, increasing the amount of these neurotransmitters in the synapse. 2. Like cocaine, amphetamine also inhibits reuptake of the catecholamines, increasing the ability to activate receptors. In addition, amphetamine inhibits monoamine oxidase, the enzyme responsible for the destruction of monoamine neurotransmitters, further increasing the availability of these neurotransmitters. And finally, there is some evidence that amphetamine may directly activate catecholamine receptors, further contributing to monoaminogenic activity. Psychopharmacological research has revealed that specific brain areas and neurotransmitters responsible for behavioral effects of psychomotor stimulants. The important prominent monoamine neurotransmitter involved in the effect of these drugs is dopamine, which is responsible for the powerful reinforcing effect, the increase in activity, and the stereotypic and psychotogenic effects. Increased dopamine activity in a forebrain region, known as the nucleus accumbens, mediates the reinforcing effects and the motor stimulant effects of the psychomotor stimulant. Dopamine in this brain region also appears to mediate the psychotogenic effects produced by high doses of these drugs. Increased dopamine activity in an adjacent forebrain region, the striatum or caudate putamen, is responsible for the stereotypic effects of the stimulants. Sedatives and behavior. Sedatives and hypnotic drugs are central nervous system depressants. They depress behavior, moderate excitement, induce calmness, and may produce drowsiness or even loss of consciousness. The sedative hypnotics are used clinically as anti-anxiety agents, muscle relaxants, anti-epileptics, and as pre-anesthetic medications. Drugs in this category include barbiturates, benzodiazepines, and anesthetics. History of sedative hypnotics. In 1903, barbital, a derivative of barbituric acid, was introduced. Its sleep-inducing and anxiolytic effects made it very popular in clinical medicine. It soon became popular as a treatment for anxiety and as the first sleeping pill. In 1912, phenobarbital was introduced. Phenobarbital, in addition to sedative hypnotic properties, has anticonvulsant properties and has become one of the most important pharmacological treatments for epilepsy. The success of barbital and phenobarbital spawned the synthesis of over 2,500 barbiturates. Of these many barbiturate analogues, only about 20 are still on the market. The effects of these various barbiturates are generally similar, differing primarily in potency and duration of action. The partial separation of sedative hypnotic anesthetic from anticonvulsant properties found in phenobarbital led researchers to search for agents with more related effects on the functions of the CNS. In the late 1930s, relatively non-sedative anticonvulsants were developed, e.g. phenytoin and trimethadone. In 1957, the first benzodiazepine, chlordiazepozide, Librium, was synthesized. Benzodiazepines have demonstrated their ability to relieve symptoms of anxiety with relatively little interference with cognitive functions or wakefulness. Benzodiazepines and barbiturates share very similar properties, but the benzodiazepines have demonstrated to have a much safer pharmacological profile. Benzodiazepines have therefore replaced barbiturates for most use, particularly for treatment of anxiety and sleep disturbances. Behavioral effects of sedatives in men. Sedative hypnotic drugs depress behavior, moderate excitement, and induce calmness. These drugs depress the central nervous system. However, they usually produce therapeutic benefits at far lower doses than those causing substantial generalized depression of behavior. Barbiturates have a wider and more powerful effect on the central nervous system than other sedatives. The barbiturates can produce varying degrees of depression of the CNS, ranging from mild sedation to general anesthesia. In low doses, barbiturates have a calming effect, and some of the barbiturates, e.g. phenobarbital, have demonstrated selective anticonvulsant properties. In moderate doses, they produce a drunken euphoric state, similar to alcohol. Sedation and sleep results from increased doses, and even higher doses produce surgical anesthesia. Because of their ability to produce sedation and decrease sleep latency, barbiturates were popular in the treatment of insomnia prior to the advent of benzodiazepines. However, because of the high incidence of tolerance and physical dependence following chronic use, and the relatively high danger of overdose, these drugs are rarely used today for the treatment of anxiety or sleep disturbances. Benzodiazepines share the sedative hypnotic property but produces fewer side effects than barbiturates. Like barbiturates, benzodiazepines have also been reported to produce anticonvulsant effects. In addition, these drugs are used clinically as muscle relaxants, anti-epileptic agents, and to produce sedation following operative procedure. The anti-anxiety effects of benzodiazepines are more sedative than those of other sedative hypnotics. They relieve anxiety at lower doses and thus produce minimal sedation and motor impairment. The benzodiazepines are currently the most important class of drugs for treatment of anxiety and sleep disorders. Mechanism of action of sedatives. Barbiturates and benzodiazepines act similarly to produce depression of the central nervous system function and behavior. Both classes of drugs enhance the ability of the inhibitory neurotransmitter gamma-aminobutyric acid (GABA) to activate a type of receptor known as GABA-A receptor. These drugs increase the effectiveness of GABA by altering the receptor so that GABA can bind more easily, an effect known as allosteric regulation. Activation of GABA-A receptors opens an ion channel, allowing negatively charged chloride ions to enter the cell, producing an inhibition of neuronal activity. In addition to barbiturates and benzodiazepines, ethanol appears to produce depression of central nervous system function, in part by enhancing the ability of GABA to bind to GABA-A receptors. This may explain why these three classes of drugs potentiate one another's effects and why tolerance to one results in cross-tolerance to another. Examples of benzodiazepines include diazepam with the trade name Valium, alprazolam with the trade name Xanax, and chlorodiazepoxide with the trade name Librium. Examples of non-benzodiazepines include buspirone with the trade name Bospa, chloral hydrate with the trade name Noctec, and zolpidem tartrate with the trade name Ambien. Hallucinogens. A hallucinogen is a general group of pharmacological agents that can be divided into three broad categories: psychedelics, dissociatives, and dereliants. These classes of psychoactive drugs have in common that they can cause subjective changes in perception, thought, emotion, and consciousness. Unlike other psychoactive drugs, such as stimulants and opioids, these drugs do not merely amplify familiar states of mind, but rather induce experiences that are qualitatively different from those of ordinary consciousness. These experiences are often compared to non-ordinary forms of consciousness, such as trance, meditation, and dreams. Hollister's criteria for establishing that a drug is a hallucinogenic include: 1. In proportion to other effects, changes in thoughts, perception, and mood should predominate. 2. Intellectual or memory impairment should be minimal. 3. Stupor Narcosis or excessive stimulation should not be an integral effect. 4. Autonomic nervous system side effects should be minimal, and addictive craving should be absent. An antidepressant is a psychiatric medication used to alleviate mood disorders such as major depression and dysthymia, and anxiety disorders such as major depression and dysthymia, and anxiety disorders such as social anxiety disorder. People with a depressive illness will experience a therapeutic effect to their mood. However, this will not be experienced in healthy individuals. Drugs including the monoamine oxidase inhibitor (MAO), tricyclic antidepressants (TCAs), tricyclic antidepressants (TECAs), selective serotonin reuptake inhibitors (SSRIs), and serotonin norepinephrine reuptake inhibitors (SNRIs) are most commonly associated with the term. These medications are among those most commonly prescribed by psychiatrists and other physicians, and their effectiveness and adverse effects are the subject of many studies and competing claims. Most typical antidepressants have a delayed onset of action, 2 to 6 weeks, and are usually administered for anywhere from months to years. Despite the name, antidepressants are often used to treat other conditions such as anxiety disorders, obsessive-compulsive disorders, eating disorders, chronic pain, and some hormone-mediated disorders such as dysmenorrhea. Some of these uses are FDA approved and some are off-label. Alone or together with anticonvulsants, e.g. Tegretol or Depakote, these medications can be used to treat attention deficit hyperactivity disorder (ADHD) and substance abuse by addressing underlying depression. Also, antidepressants have been used sometimes to treat snoring and migraines. Hallucinogens, also known as psychedelic drugs, are drugs that change the way a person perceives the world. Hallucinogens affect all the senses and causes hallucinations, seeing or hearing things that do not exist or are distorted. A person's thinking, sense of time and emotions can also be altered. There are many different kinds of hallucinogens. Some occur naturally in trees, vines, seeds, fungi and leaves, while others are manufactured in laboratories. Hallucinogens include LSD, magic mushrooms, mescaline, PCP, phenylcyclidine. Naturally occurring hallucinogens have been used since ancient times by various cultures throughout the world, particularly by the indigenous people of North and South America for their mystical and spiritual associations. Hallucinogens became very fashionable in the United States and Europe in the 1960s when many young people were pursuing greater personal freedom and questioning old values and ideas. Types of hallucinogens: lysergic acid diethylamide (LSD), acid or trip, is one of the most commonly used hallucinogens. It was invented in 1938 and explored as a treatment for some illnesses. During the 1960s, LSD became the drug of choice of the hippie culture. Since then, its use has declined, but there is some recent evidence of increased popularity. In pure state, LSD is a white and odorless powder. It usually comes in the form of a liquid or as a tablet or capsule, squares or gelatin, or blotting paper. LSD is swallowed, sniffed, injected or smoked. It is very potent, with small amounts causing strong effects. For easier handling, LSD is often diluted with other substances such as sugar or soaked into sheets of blotting paper. Phencyclidine (PCP) or angel's dust, as well as effective, similar to LSD. The effects of PCP include euphoria and numbness. Heavy use can cause PCP psychosis with aggression, paranoia, and violent or suicidal behavior. Methylene dioxymethamphetamines (MDMA/ecstasy). Ecstasy is like both amphetamines and hallucinogens in chemical structure and effect. It is usually swallowed, but sometimes is also injected. Ecstasy can have hallucinogenic properties when used in high quantities. Magic mushroom or golden top mushrooms. They have the active ingredient psilocybin. They can be eaten fresh, cooked, or brewed into a tea. Small quantities cause relaxation and slight changes in mood, but larger quantities can cause stomach pain, nausea and vomiting, shivering, a numbing of the mouth, and dizziness. People can mistake poisonous mushrooms for those containing psilocybin. Certain kinds of these poisonous mushrooms can cause death or permanent liver damage within hours of ingestion. A number of other mushrooms and plants that grow in Australia have hallucinogenic properties, but also have dangerous toxic side effects when insufficient quantities are used to give the psychedelic effect. These include datura, the belladonna plant, and fly agaric mushrooms. Cannabis, marijuana. In small quantities, cannabis is a depressant drug that slows down the body system. Very strong cannabis preparations or large quantities of cannabis can cause mild hallucinogenic effects. These can lead to anxiety or panic in the user. Effects of hallucinogens. The effects of any drug, including hallucinogens, vary from person to person. It depends on many factors, including the person's size, weight and health, how much and how the drug is taken, whether the person is used to taking it, whether other drugs are taken, whether use is combined with drinking alcohol, the environment in which the drug is taken. For example, whether the person is alone or with others, such as at a party. More than with any other drug, the effects of hallucinogens vary greatly from person to person and from occasion to occasion. It is hard to know how the hallucinogenic experience or tripping will affect the person. Days, weeks, or even years after using the drug, some people have a repeat experience of the effects, flashback. The user may see intense colors and other hallucinations. Flashbacks can be sparked by the use of other drugs or by stress, fatigue, or physical exercise. The flashback experience can range from being pleasant to producing severe feelings of anxiety. They are usually visual and last for a minute or two. Hallucinogens' effects on the brain. Hallucinogens alter the way the brain perceives time, reality, and the environment around you. They also affect the way you move, react to situations, think, hear, and see. This may make you think that you are hearing voices, seeing images, and feeling things that don't exist. Hallucinogens' effect on the heart. The use of hallucinogens leads to an increase in heart rate and blood pressure. Hallucinogens can put you in a coma. They can also cause heart and lung failure. Hallucinogens affect your well-being. The use of hallucinogens may change the way you feel emotionally. They may cause you to feel confused, suspicious, and disoriented. Use of PCP may interfere with hormones related to normal growth, as well as with the learning process. Hallucinogens affect self-control. The impact of hallucinogens varies from time to time, so there is no way to know how much self-control you might maintain. They can cause you to mix up your speech, lose control of your muscles, make meaningless movements, and do aggressive or violent things. Hallucinogens and pregnancy. The use of hallucinogens seems to be linked to an increased risk of miscarriage. There may be a higher incidence of birth defects among babies born to women using hallucinogens. Hallucinogens and driving. It is illegal to drive while under the influence of any drug, including hallucinogens. Breaking this law carries penalties, including disqualification from driving, fines, and/or imprisonment. It is also extremely dangerous to drive after using hallucinogens. Perceptions of space and time is distorted, and the user may see things that will cause erratic driving. The combination of drugs and alcohol can make driving significantly more dangerous. Treatment options. A number of drug treatment options are available. Some treatment options include counseling and withdrawal, detoxification, and residential programs are available. Antidepressants and behavior. Antidepressants are a class of psychotherapeutic drugs that are used to treat major depression. The therapeutic effect of antidepressants aims at the restoration of mood and behavior. The major types of drugs included in this class are the monoamine oxidase inhibitors, tricyclic antidepressants, selective serotonin reuptake inhibitor, and atypical antidepressants. What is depression? Major depression is one of the most common psychiatric disorders afflicting humankind. It has been estimated that 7 to 12% of men and 20 to 25% of women will experience a major depressive episode in their lifetime. However, because of stigma, misunderstanding about the seriousness and treatability of the disorder, and the tendency of both parents and physicians to focus on physical rather than psychological symptoms, it often goes undiagnosed and untreated. The cost of depression in terms of loss of function, work missed, and treatment has been estimated to be $16 billion per year in the United States alone. The human cost is significant as well, with as many as 80% of attempted suicides contributed to major depression. It is important to distinguish major depression from normal fluctuations in the mood in response to daily events. Although nearly everyone experiences a depressed mood on occasion, major depression is characterized by extreme and inappropriate or chronic and unremitting changes in mood and behavior. The diagnosis of major depression is based on clinical symptoms. To be considered clinically depressed, individuals must exhibit at least 5 symptoms from a list of 9 depressive symptoms from the DSM-4. At least one of the symptoms must be either 1. Depressed mood, or 2. Loss of interest or pleasure. Major depression is believed to arise from disturbances in brain neurotransmitter systems. As stated in recent public service announcement by the National Alliance for Research on Schizophrenia and Depression (NASRAD), depression is a flaw in chemistry, not character. Antidepressant drugs help restore the chemistry of the brain so that normal mood and behavior can take place. History of antidepressants. The first two classes of drugs used to treat major depression, the monoamine oxidase inhibitor and the tricyclic antidepressants, were discovered by serendipity. Iproniazid, the first modern antidepressant, was originally developed as an anti-tubercular drug in the early 1950s. In addition to its ability to treat tuberculosis, iproniazid was observed to alleviate mood and stimulate activity in many patients. This effect led researchers to investigate the ability of iproniazid to treat the symptoms of depression. After promising preliminary findings reported in 1957, iproniazid was prescribed widely to patients with major depression. Within the first year, it was available as an antidepressant. 400,000 depressed people were treated with iproniazid. Subsequent studies demonstrated the ability of this drug to block the activity of monoamine oxidase, the enzyme that destroys the monoamine neurotransmitter, norepinephrine, serotonin, and dopamine. Although iproniazid is no longer used as an antidepressant because of toxic side effects, the effectiveness of this drug led to further interest in the idea that depression might be alleviated by appropriate drugs. The first tricyclic antidepressant, imipramine, was originally developed in a search for drugs useful in the treatment of schizophrenia. Although clinical trials demonstrated a lack of effect in treating schizophrenia, an astute clinician decided to examine its effectiveness in depressed patients. Early studies in 1957 and 1958 reported that imipramine significantly alleviated symptoms in patients with major depression. Interestingly, although imipramine elevated mood and increased energy in depressed patients, the drug proved to be sedating in individuals without major depression. This effect led to the idea that imipramine was selectively reserving the depression, rather than simply producing a general activating effect. Subsequent biochemical studies on imipramine demonstrated that this drug increased the activity of the monoamine neurotransmitter, norepinephrine and serotonin, by inhibiting their reuptake into neurons. The monoamine oxidase inhibitor and tricyclic antidepressants, although having different modes of action, have as their primary effect an increase in the activity of monoamines in the brain. This observation, together with their findings, led to monoamine theory of depression, the idea that depression arises from a deficit in norepinephrine and/or serotonin activity, and that antidepressants work by normalizing these deficits. This theory led to the development of the next major class of antidepressants, the selective serotonin reuptake inhibitors (SSRIs). In order to develop an antidepressant that worked effectively on the symptoms of depression, but they did not have the side effects of the MAOIs or the tricyclics, a systematic search was begun for drugs that selectively enhanced activity of one monoamine but not others. The first SSRI, fluoxetine Prozac, was released in 1987. This drug and other SSRIs, as the name imply, selectively inhibit the reuptake of serotonin and thereby increase serotonin activity in the brain. Current theories of antidepressant action. Monoamine hypothesis. Shortly after the first antidepressant drug was introduced, they were demonstrated to increase the availability of the monoamine neurotransmitter, norepinephrine and serotonin. Monoamine oxidase inhibitor (MAOIs), as the name implies, inhibits the enzyme monoamine oxidase. This enzyme is the primary enzyme responsible for the inactivation of monoamines after they are released from neurons. Blockade of MAO therefore increases the ability of norepinephrine and serotonin to act in the brain. Tricyclic antidepressants inhibit reuptake of norepinephrine and serotonin, while selective serotonin reuptake inhibitors (SSRI) inhibit reuptake of serotonin selectively. Following release from neurons, norepinephrine and serotonin are actively transported back into the neurons from which they are released, in a process known as reuptake. In addition to inactivation by MAO, reuptake is one of the most important processes by which monoamines are inactivated in the brain. Blockade of reuptake therefore increases the ability of norepinephrine and/or serotonin to act in the brain. The majority of antidepressants thus have as their principal effect an increase in the activity of serotonin and/or norepinephrine. These findings form the basis of the monoamine hypothesis of depression. Since antidepressant drugs increase the activity of monoamines, this hypothesis suggests that depression is primarily the result of a monoamine deficit. Although the monoamine hypothesis is pleasing in its simplicity, it has several major flaws. First, it has been difficult to detect consistently abnormalities in monoamine functions in depressed people. Additionally, some antidepressants such as iprindole and bupropion are at best weak inhibitors of monoamine reuptake. Finally, this hypothesis does not account for the temporal discrepancy between the acute effects of the antidepressant drugs on monoamine systems, which occur within minutes to hours, and the therapeutic benefits, which typically occur only after 2 to 6 weeks of administration. Because of these flaws in the classical monoamine hypothesis, other hypotheses have been proposed. The majority of these hypotheses still suggest a disturbance in monoamine function. However, the disturbance is considered to be more complex than a simple deficit in brain monoamines. Chronic administration of antidepressants is thought to produce adaptation in monoamine systems, correcting the disturbances responsible for depression. These hypotheses therefore account for the need to administer antidepressants for several weeks to achieve therapeutic benefits. Mechanism of action of antidepressants. Monoamine oxidase inhibitors. This class of drugs inhibits the activity of monoamine oxidase (MAO), the enzyme that destroys monoamine neurotransmitters, norepinephrine, dopamine or serotonin, in synapses. The inhibition of this enzyme allows these neurotransmitters to remain active in the brain longer, thereby correcting a presumed deficit in monoamine function. Unfortunately, MAO inhibitors have the potential for producing a harmful side effect known as the cheese effect. Some foods such as aged cheese and red wine contain presoamines, substances similar to catecholamines. These amines are normally deactivated by a form of MAO that is present in the blood. The cheese effect occurs when a person treated with MAO inhibitors eats food containing prosoamines. These amines stimulate the sympathetic nervous system, increasing heart rate and blood pressure. This reaction can cause blood pressure to increase enough to produce intracranial bleeding or cardiovascular collapse. Therefore, unless strict dietary guidelines are followed, risk of hypertensive crisis is significant. However, when appropriate precautions are exercised, MAOIs are safe and effective antidepressants. The three MAOIs marketed in the US irreversibly inhibit both forms of monoamine oxidase found in the body, MAOA, MAOB. MAOA preferentially destroys norepinephrine and serotonin, while MAOB selectively destroys phenethylamine when administered initially. MAO inhibitors transiently elevate the cytoplasmic and vesicular concentrations of norepinephrine, dopamine and serotonin. This activates a feedback loop that reduces the synthesis of these monoamines. If administration continues, there is a reduction in the number and activity of beta-adrenergic receptors, as well as in the number of alpha-2 adrenergic and serotonergic receptive sites. Examples of this group of antidepressants include phenelzine with the trademark Nadil, tranylcypromine with the trade name Panate, and isocarbonaxide with the trade name Marplan. Tricyclic antidepressants. Tricyclic antidepressants inhibit the reuptake of the neurotransmitters serotonin and norepinephrine into their respective nerve terminals. Reuptake is the first step in the process of deactivating these neurotransmitters in the brain before serotonin and norepinephrine are released from neurons. They are removed from the extracellular space by transporters also known as reuptake sites located on the cell membrane. The tricyclic antidepressants block these transporters by inhibiting reuptake. The drug allows serotonin and norepinephrine to remain active in the synapse longer, thereby correcting a presumed deficit in the activities of this neurotransmitter. It includes examples such as imipramine with the trade name Tofranil, desipramine with the trade name Nopramil, amitriptyline with the trade name Elavil or Endeb, and trimipramine with the trade name Sumontil. Selective serotonin reuptake inhibitors. The SSRI, as their names imply, inhibit reuptake of serotonin. Reuptake is the first step in the process of deactivating this neurotransmitter in the brain. After serotonin is released from the neurons, it is removed from the extracellular space by transporters or reuptake sites located on the cell's membrane. SSRIs block serotonin reuptake sites, allowing serotonin to remain active in the synapse longer, thereby correcting a presumed deficit in the activities of this neurotransmitter. They include examples such as fluoxetine with the trade name Prozac, fluvoxamine with the trade name Levox, and paroxetine with the trade name Pavel. Atypical antidepressants include bupropion with the trade name Wellbutrin and venlafaxine with the trade name Effexor. Behavioral effects of antidepressants on humans. Monoamine oxidase inhibitors. The MAO inhibitors are effective drugs for the treatment of major depression, atypical depression, and panic or phobic disorders. The efficacy of MAO inhibitors is generally equivalent to the other classes of antidepressant drugs. And like other antidepressants, MAOI may take anywhere from 2 to 6 weeks to produce therapeutic effects. Tricyclic antidepressants. The name tricyclic is a little misleading, referring to the three-ring chemical structure of many of the drugs of this class. Drugs included in this class may actually contain anywhere from 1 to 4 rings. From the 1960s until the late 1980s, tricyclic antidepressants were the drug of choice for the treatment of depression in the United States, and they are still widely used for moderately to severely depressed patients. Tricyclic antidepressants elevate mood, increase physical activity, normalize appetite and sleep patterns, and reduce morbid preoccupation in 60% to 70% of patients with major depression. Like the other classes of antidepressants, therapeutic effects of the tricyclics may take from 2 to 6 weeks to appear. Often, the first symptom to subside is insomnia, followed a few days later by an increase in activity and an improvement in concentration and memory. Improvement in mood does not usually occur until later. Selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors (SSRIs) represent a relatively new class of antidepressant drugs. These drugs are referred to as clean drugs because they primarily affect only serotonin, in contrast to MAOIs and tricyclics, which affect other monoamines. Because SSRIs are more targeted, they have a lower incidence of some of the side effects associated with tricyclic antidepressants and MAOIs. Example: blurred vision, dizziness, constipation, dry mouth. More important to their current popularity, SSRIs have less potential for overdose than the tricyclics or MAOIs, and are therefore considered safer than those other drug classes. Although some reports suggest that SSRIs may have more rapid action than the tricyclics or the MAOIs, this does not appear to be the case. Like the other cases of antidepressants, clinical response to the SSRIs may take anywhere from 2 to 6 weeks to appear. Study session summary. In this study session, we discussed the following. Drugs are chemicals. They work in the brain by tapping into the brain's communication system and interfering with the way nerve cells normally send, receive, and process information. Drugs can be classified by molecular structure, biochemical action, and behavioral effects. Classification of drugs according to behavioral effects is of interest to psychologists, including psychostimulants, sedatives, hallucinogens, and antidepressants. Reuptake is the first step in the process by which monoamines are destroyed in the brain. Hallucinogens are known as psychedelic drugs, are drugs that change the way a person perceives the world. Hallucinogens affect all the senses and cause hallucination, seeing or hearing things that do not exist or are distorted. A person's thinking, sense of time, and emotion can also be altered. Types of hallucinogens include lysergic acid diethylamide, PCP, and ecstasy. Sedative and hypnotic drugs are central nervous system depressants. They depress the behavior, moderate excitement, induce calmness, and may produce drowsiness or even loss of consciousness. The sedative hypnotics are used clinically as anti-anxiety agents, muscle relaxants, anti-epileptics, and as para-anesthetic medications. Drugs in this category include barbiturates, benzodiazepines, and anesthetics. These drugs depress behavior, moderate excitement, and induce calmness. They depress the central nervous system. However, they usually produce therapeutic benefits at far lower doses than those causing substantial generalized depression of behavior. The effect of any drug, including hallucinogen, vary from person to person. It depends on many factors including the person's size, weight and health, how much and how the drug is taken, whether the person is used to taking it, whether other drugs are taken, whether use is combined with drinking alcohol, the environment in which the drug is taken, for example, whether the person is alone or with others such as at a party. Antidepressants are a class of psychotherapeutic drugs that are used to treat major depression. The therapeutic effect of antidepressants aims at the restoration of mood and behavior. The major types of drugs included in this class are the monoamine oxidase inhibitors, tricyclic antidepressants, selective serotonin reuptake inhibitors, and atypical antidepressants. End of study session 8. Thanks for listening.